Good evening to all, and welcome to tonight's MS Views and News program on this important topic of COVID vaccine updates and a Q&A, okay? My name is Stuart Schlossman. It says it right on that screen. That's how I know it's me, okay? And I'm the president and founder of MS Views and News, and I too have multiple sclerosis. And this journey began a long time ago. But I just want to let you know that tonight's program is solely supported by MS Views and News. We wanted to, we needed to, we knew we had to be able to provide this information because, you know, I'm on social media a lot, and I see people giving crazy answers to questions that they should be letting the experts like a Dr. Singer to be able to answer. All right, so we want to ask Dr. Singer to be on here tonight. And speaking of Dr. Singer, so Dr. Barry Singer has never spoken for MS Views and News in the past. This is the first time, and it's so, you know, I had to have him on here. It was awesome. But Dr. Singer is the medical director at the MS Center for Innovations in Care at Missouri Baptist Medical Center. Sorry for that. That's in St. Louis, Missouri. His website he has is mslivingwell.org, and I'm sure you could find that afterwards. Also, he's on Twitter. He's very big on Twitter. He is not on Facebook, all right? And his Twitter handle is at Dr. Barry Singer. You could find him on there. You can find this information on this resources page that we have up right now. Is actually in the handouts section. So again, in the information that's in the information on the scroll bar, you could see the word handouts, and you could click on that, and you could print it out if you want. And we will have it available as well when we put this up on our YouTube channel. Okay, so tonight, Dr. Singer is going to speak briefly, and then we're going to be doing an extensive Q&A on the topics pertaining only to this program. If your question is not asked, it may be because it has nothing to do with this program, all right? Or it also could be because the question has already been asked and answered. And so we cannot be here for 2 hours, although we'll be here close, maybe 60 to 90 minutes, okay? But we don't want to be duplicating questions and answers. So another thing I want to make mention of is a lot of people text me or they send messages to me on here saying that they can't hear anything. Well, if you can hear me right now, then your sound is working. And if you cannot hear in a few minutes, then we're going to ask you to reboot and get back in again, because it's just something with your connection, or just hang out for a few moments. Maybe it has something to do with your server. All right. And again, if you want to ask a question, type it in if it's not already sent to us. And for now, though, I want to welcome Dr. Barry Singer, and let's get started. And I'll be back in 10 minutes when he's done speaking.
All right, thanks, Stuart. Well, it's great to be with the audience here at MS Views and News. It's it's actually my first time with you all, as Stuart mentioned, and it's a pleasure to be here. We know right now it's kind of a very stressful time. I run a comprehensive MS center here in St. Louis, and so a lot of people are worried about COVID and have a tremendous amount of questions about getting vaccinated. Is it safe for me? And so a tremendous amount of questions are arising. So I'm really glad to have the chance to answer as many questions as we can tonight for you. Just a little overview of vaccinations and MS. And so in general, vaccinations are recommended for people with multiple sclerosis. And we tend to find that, big question is, if I get vaccinated, is that going to trigger a relapse? We hear about occasionally vaccinations associated with Guillain-Barré syndrome, which is an immune attack on the nerves. The good news is we don't really have evidence for that. So with multiple sclerosis, we have not shown that people that got vaccinated get relapses. There was initially some concern about hepatitis B vaccine, and of course, hepatitis B can kill you from liver disease. But later studies have not shown that to be true. So at this point, we don't have any vaccines that trigger MS relapses. So I think that's very important to know. Most people with MS should get routine vaccinations. So after 50, everyone should be vaccinated with Shingrix, which is a killed chickenpox vaccine. And the idea behind that is that you don't get shingles, which can be extremely painful, and some people have residual pain after getting shingles. And so that would be one that you would want to get. When you're a kid, most people would get diagnosed with MS, not as children, although we do have children with MS. but most people have already finished their childhood inoculations. Sometimes, for the most part, vaccines that are not live are safe with people with MS. So there's not too many live or live weakened viruses vaccines. So example would be varicella. There is a chickenpox vaccine that can be given to people who have never been immunized for chickenpox and never had chickenpox. And so sometimes I'll see people in their 20s and 30s, and they've never had the chickenpox virus. Well, that's going to be an issue on some MS drugs, and there's a risk. So we want to make sure that those patients are vaccinated, and that would be a live attenuated virus. So for those people, we want to make sure they're vaccinated before they go on treatment. Measles, mumps, and rubella is a live vaccine, so we would want to avoid that. And some people, if you want to go to Brazil or Africa, there's yellow fever, which is a live vaccine. But most are killed. For example, flu vaccine. So we know that flu vaccine is important for people with MS, and so that's okay to get the flu vaccine. Now, the question is, can you get a COVID-19 vaccine if you're living with multiple sclerosis? And the bottom line is yes. At this point, we do not see any reason why the ones available in the United States are the mRNA vaccines. So we have the Pfizer and Moderna vaccine, and neither one of them will replicate in your body. Basically, what these vaccines are coding strands. So there's these little strands of mRNA. And when that's injected into your body, it goes into your muscles and into your muscle cells. And then that coding strand makes a protein called the spike protein. And so those muscle cells then have little spikes on the surface. Your immune system sees that and says, whoa, what are these spikes? And creates a group of T cells and B cells that are ready to react to it. The advantage of that is if you ever got exposed to the actual COVID-19 virus called SARS-CoV-2, then you have the ability to attack the spikes on the surface of that virus. And so the beauty of it is that you'll mount an immune response and clear that virus from your system. Because the vaccine only makes that spike protein, it can't replicate, it can't divide. In fact, the mRNA is degraded in your body. So your cells degrade it and the spikes go away. So it's really a transient exposure to this vaccine that allows you to mount an immune response. So if you got exposed to COVID-19, you were ready to fight. So again, we don't see any reason that it's not a live virus, it's not going to replicate or divide in your body. So we think it's quite safe. Now, the big question comes up, it's not if it's safe or not, is are you going to respond to the vaccine? So we want to know on our MS drugs, because MS itself, your immune system's overactive. So that's not the problem. The problem is some of our MS meds suppress the immune system. So they dampen down the immune system. So the immune system is not as revved up. And as a result, because the immune system's dampened on these various medications or immunosuppressed, you may not mount a great response to a vaccine. It may not be as good on certain MS medications. I'll give you an example. So there was a study done in Norway, and they looked at the flu vaccine, and they looked at a specific strain called H1N1. And they looked at antibodies, people that developed antibodies after vaccination for H1N1, and in 152 people. And included some people that were healthy, that had no MS and didn't have any issues. And 94% of people responded to the vaccine. If you looked at Copaxone or interferons, Copaxone was 86% of people responded to the vaccine, 84% for interferon. When you got to Gilenya, it was 58% of people responded, and Tysabri 75%. So you can see some of our MS medications you may not respond as well to a vaccine. So we think this is probably going to happen with COVID-19 vaccines, that instead of 95% of people who get the vaccine are protected, on some of our MS medications, you may not respond as well. So it is important to keep in mind that once you get vaccinated, that you can't just rip off your mask and go off and pretend like you're totally immune. There is a chance that you may not be protected. Now, some of our MS drugs, we see this probably going to be a bigger factor. The drugs that deplete B cells, for example, which include Ocrevus and Kesimpta, some of our S1P agents, such as Gilenya, Zeposia, Mayzent. So some of our agents might diminish that response a little bit more. I mentioned Tysabri, the data looks fairly good. When we start thinking about other drugs, though, you look at medications, there's some vaccination data with Tecfidera, for example, that's pretty positive in terms of response to vaccines. So again, we don't have data on COVID-19 yet. So we still don't know, in various MS meds, how this all pans out. Now, a big interest is timing of medications. And so, if you know when you're going to get your COVID-19 vaccine, is it an advantage to wait on a treatment of your MS medication? Should you hold your MS medication so you get a good response to the vaccine? So most of our MS meds, we're not going to change anything. So if we think about patients that are on the interferons, which include Rebif and Betaseron, Avonex, Xtavia, Plegridy. So if you look at those medications, you're not going to really discontinue those medications. Same thing with glatiramer acetate or Copaxone. If we look at Aubagio, and Tecfidera, Vumerity, dimethyl fumarate, these agents, we're probably not going to change our treatment strategy. And similarly with our S1P drugs like Mayzent, Zeposia, and Gilenya, we're also not going to really change the medications. If you stop some of these medications, the medication can rebound and cause more disease activity. And so with some of these drugs, we're not going to change that. Now, you have a couple drugs that are not given regularly, and so timing may be of interest for them. For example, Ocrevus is an IV infusion every 6 months. And Ocrevus knocks out B cells. So you potentially don't have any B cells at 6 months after the infusion. And so what we may want to do is try to get your COVID vaccine in right before your next infusion. So there may be some advantages there. And so if you wait 2 to 4 weeks after your last infusion, after you get vaccinated, you may have some benefit there. Another drug would be, for example, Mavenclad, which is an oral medication that you take. You take one course of it, and then a month later you take a second course, and then you're good for a year. And so timing of the medication counts tip a little bit, not a lot, in terms of white blood cell counts, specifically lymphocytes. And that tends to happen at 2 to 3 months after you're given a course. So we may want to look at timing in relation to your dosing of your medication to find the optimum time to get the medication. Again, this is all challenging because of, you don't know when the vaccine is going to be available to you and when you get that email that says, come on in and get vaccinated. Same thing with Lemtrada, which is an IV treatment where it can really knock down your counts initially that first few months after the infusion. So you may want to time that beforehand. So again, it is important that we look at timing of medications. So it's always very, very important that you contact your neurologist, your healthcare providers, and come up with a game plan that's right for you.
Excellent. Excellent. Do you have more that you want to tell them, or do you want me to start with questions?
Well, let me just talk about a couple resources that can help. So if you have information about timing of the medications, so one of the good links that I supplied here is with the National MS Society. So they have a statement about vaccinations on COVID. They assembled a panel together, and then they also list about timing of medications. So you could take a look at that, and they list all the specific disease-modifying therapies. In terms of like your ability to respond to vaccines, I have information on MS Living Well in the blog section, and there's a link there as well. So you can go and learn about, how these vaccines work, COVID-19 vaccines, and how do people respond to various vaccines are on there. So on various MS medications, how well do I respond to vaccines? And then I also I'm a podcaster, so I have an MS Living Well podcast, and there's a podcast link where I interview two MS specialists. They're immunologists, Dr. Ann Cross and Dr. Amit Baror at Penn, and Cross is at WashU. Washington University here in St. Louis, and we talk about all these issues. So if you're into podcasting, check out the MS Living Well podcast on the same topic.
Okay. That's it? Got more?
Well, I'm ready. Let's do questions.
Okay, great, great. Really I just didn't know when you're going to be ready for it or not. So, well,
I'm ready.
Thank you for providing all that information. And yes, everybody, it was a lot, right? And you can't imagine how you're going to remember this, right? Okay, well, we don't actually expect you to remember. So again, this program will be up on our YouTube channel before the weekend, all right? So my video producer now knows that I said that. He now knows that I need to have this immediately. Okay, so we will have this up before the end of the weekend, I'll say, okay? All right, great. So with this COVID Q&A, let's begin. So the first one was, I've heard people with MS should not get a vaccine. Is it okay for an MS patient to get the COVID-19 vaccine?
Yeah, so as I mentioned, definitely COVID-19 vaccinations are recommended for people with multiple sclerosis. Really, and as a general statement, if you've had severe reactions to immunizations in the past, then that's something to be talk that over with your healthcare providers. So if you had a severe anaphylactic reaction to a vaccine before, but you should talk to their providers. But otherwise, there's a very few contraindications, which means there's very few reasons why we would not vaccinate you for COVID.
Okay, thank you. All right, next, please discuss the administration of the COVID-19 vaccine with regard to the various MS medications. Does any special timing need to be considered with any particular DMTs, and which meds in particular?
Right. So as I mentioned as well, when we look at the specific timing, you want to look at the medications that are not given regularly. So if you're on a medicine that's administered on a regular basis and you take it daily, we're probably not going to stop that medication. So many of our oral medications, we're going to keep you on those medications and not discontinue them. The self-injected medications in terms of interferons or glatiramer acetate, we're going to keep people on. So the ones that are given more periodically, if you look at the medications, for example, Mavenclad that I mentioned, the oral medication, and then if you look at Lemtrada, which is an IV treatment, and Ocrevus, which is an IV treatment. Since these are not given consistently, they may be given annually or every 6 months, then it is an opportunity to look at that timing. So if you can get when your immune system is bouncing back, that may be the time to get the dose in so that your immune system can respond better to the vaccine. Now, with some drugs, for example, Ocrevus and Kesimpta, Kesimpta is a drug that also knocks out B cells, and so does Ocrevus, so they knock out or deplete B cells. Before you get your next dose of Ocrevus, your B cells may be coming back. We know Kesimpta also lasts for months after administration, so there is some guidance from the National MS Society about potentially holding a Kesimpta dose or timing it around the Kesimpta dose. I'm not sure in my practice, I pretty much have continued to vaccinate patients while keeping them on their monthly Kesimpta.
Thank you. Going further with something similar to this is, what can you, how will the vaccines interact with the B cell therapies?
Yeah, so the concern is with B cell therapies. So B cell therapies would include Ocrevus and Kesimpta. Some patients are on, based on their managed care, maybe on Rituxan or rituximab, although not FDA approved for the treatment of MS. And so these drugs knock out B cells. So you basically don't have B cells on the therapy. And very few patients by 6 months have significant amount of B cells. So you basically are continuously no B cells. So B cells form plasma cells, and plasma cells make antibodies. So that's part of our immune response. And so, with MS, these B cells can lead to damage. So antibodies can actually attack myelin. So the idea of knocking out B cells and preventing plasma cells and preventing the antibodies forming, can make a big difference in shutting down the disease. The effects on MRI are very, very strong with these B-cell depleting medications. So, but the downside is you may reduce the ability to respond in terms of making antibodies, as I mentioned. For example, there was a Vaccination trial that was done in the flu vaccine, and you found patients on response to the flu vaccine, but 56 to 80% on Ocrevus. So we think on COVID vaccine that people may not mount as great a response on these B-cell depleters. So if we wait until some of the B cells come back up a little bit, there may be a window of opportunity where you might get some better response to the vaccine if the timing works out. So again, we may want to try to vaccinate you just before that 6-month window before you get your next infusion. But the bottom line, we don't want to delay it too long because the B cells will start to come back and the disease activity can come back. So it's just that we don't have good data on this yet, so it's just hypothetical. Timing may be an advantage. Now, the one good thing about B cells, despite B cell therapy, is your ability to fight viruses is not just based on antibodies, mounting an antibody response, which is a B cell response. It's also important that we have T cells that can fight viruses. And with the patients that are on Ocrevus and Kesimpta still have T cells. And Pfizer presented some really good data that show that the vaccine mounts a good T cell response. So your T cells are able to respond to the virus. And so with a vaccination, with the Pfizer vaccine, for example. So even though the B cells are kind of depleted, you still got T cells in your body that may be able to fight the vaccine. And that's much harder to measure. So that requires taking blood out of the arm and doing experiments in the lab, and so much harder to show. So we tend to measure antibody responses, which is more the B cell response.
Great. That was a lot.
That's a lot.
That was a lot. Yeah,
trying to explain it. You still got T cells is the bottom line.
I realize that. So what is the difference between the vaccines? What's the difference with the ones out currently, the mRNA versus like the Johnson & Johnson to be doing it as only one shot? Can you tell us briefly?
Right. So the two that are available are mRNA. So the mRNA basically is a coding strand, and once it's actually covered, it's pretty cool. It's a technology they've been working on for about 17 years, and it's wrapped in a little layer of fat. And so it's just this little coding strand that gets injected into the muscle. It gets into the cells, but not where the DNA is in the nucleus, and it just creates the spike protein. The adenoviruses, which is the Oxford, AstraZeneca, and the J&J vaccines, are called adenovirus. And it's kind of cool. The AstraZeneca, I don't know who had this job, but they isolated that virus in chimpanzee poop. So I don't know who went out to the jungle to find that one. But they found this little virus, adenovirus, and they engineered it to stick in the spike protein. So the DNA that makes the spike protein of the COVID vaccine, of the COVID virus. So they put the spike into this adenovirus. And adenovirus is similar to what cold viruses are. So they basically took a pretty benign virus and they stuck in the spike protein. So we inject that. It's a DNA virus. It gets into the nucleus of the cell. Doesn't get into your DNA, but it gets into the cell, and it creates that spike protein as well. So that's the idea behind it. And again, that would get degraded. The DNA would get degraded, but you're expressing the spike protein. But it's an actual virus, but it's not a live virus. It can't start replicating and dividing into the body. So it has no machinery to divide. It's just going to locally and not spread. Not available in the United States, either one of these. And there's actually another one, more of them. There's one in China, Sputnik. So there's a bunch of adenovirus vaccines out there. I know my colleagues in the UK have been vaccinating patients with the Oxford AstraZeneca virus vaccine, and it sounds like things are going well there, but not available in the United States. And we'll have to see when it comes to the U.S., if there's emergency use authorization, what it says about people that are on medications like disease-modifying therapies for MS.
Okay. I don't know about anybody else, but I do know that if somebody told me that I had to take a vaccine that was made in China, it's not happening. All right. Really not happening at this point in time. I don't care if it's the last one out there. It's not happening. All right. So, but that's my opinion. All right. So, going forward with this, are there any other safe? Are there other vaccines that are safer for the MS patients that are not mRNA? I mean, that is what you were just explaining, I believe.
Yeah, I mean, the two that are available are mRNA. I think by the time, J&J, so they looked at one dose. They have two trials going on. They had one where they gave one dose and then another one where they gave two doses. And the two-dose trial, we're waiting to see what those numbers are, but the one dose wasn't quite that 95% protective rate. So I'm really eager to see what the two-dose study showed. With two doses, so you get one vaccine, so you create a group of B cells and T cells ready to attack that spike on the surface of the virus. But then when you get you get vaccinated again, then you mount even a greater response because these immune cells, T cells and B cells, have memory. So you get exposed again, then they really are ready to respond. So that's why you're getting better protection with the second vaccine. So we'll have to see. Interestingly, the AstraZeneca, they accidentally gave people half dose with the first dose and full dose with the second, and that group of patients responded the best. So again, it takes two doses to really mount a really good response.
Okay. All right. I don't know if you said it before when you were talking all about the Johnson & Johnson. Did you say that the Johnson & Johnson vaccine is a live virus or a dead virus or no virus?
Well, it's not really live, theoretically. I've talked to some immunologists about this. In fact, I brought it up on my podcast on the topic. So it's an actual virus, adenovirus, but it can't replicate. So that's where we really defined it as, is it a replicating virus? Replicating means once it gets into your body, can it divide and multiply and spread? Or once it gets in your body, it can't do anything but make the protein that it's allowed to make. And so that's what it really is. So I think it's a bit of semantics. Someone told me emphatically it's not live, immunologist, but I think it's basically non-replicating. So, we think about things that can divide and multiply. So some of our viruses are live, can do that. So they're live vaccines that can multiply and divide in the body. And so the idea is it kind of spreads quickly and creates immunization quickly. But neither one of these are replicating. They can't divide once you get in your body, and that's why my colleagues in the United Kingdom feel comfortable giving it to people with MS on drugs that suppress the immune system.
Okay. All right. I don't mean to shorten you up because we got so many questions to talk about.
All right,
that.
I'll keep them short.
If we have any way to just make the answers a little bit shorter, then
short versions.
If it's a yes or a no, then just say yes or no and don't give the whole explanation.
Speed question.
Okay,
thank you. Let's do it.
Do you know the long-term side effects that are possible to have with the Moderna vaccine?
So at this point, when you look at, in fact, I was on the FDA advisory meeting. I was listening to that on the Pfizer vaccine, and all the vaccine experts say that it's very rare with any vaccine to see complications after 60 days. So at this point, we're not seeing a lot of significant adverse events from these vaccines, in particular the Pfizer Moderna vaccine.
Okay. All right. Great. Not great, but not great. Great that you answered, but not always great to hear the answers. All right.
So far, we've never seen long-term problems with the vaccines in general. So we would expect if we're seeing problems, we'd see it within 60 days. And that's true of the history of vaccines.
Okay. Is there a difference in efficacy among the Pfizer, Moderna, or the Johnson & Johnson vaccines?
So the Pfizer Moderna were very similar, 94, 95% protected. So no real difference. And that's what's available in the United States. Moderna, J&J, we'll have to see once we get the two-shot vaccine data in. And then the group that did well on AstraZeneca were the ones that got the half dose with the first dose and then a full dose the second time.
Okay, thank you. Now, here comes some really interesting questions. What happens if a person had one vaccine of one of the mRNAs and then misses the second one or can't get it, maybe because they got the first one at not to be known as a true vaccine site? But, you hear about all these people that they're finding a pharmacy that has extra doses and they go in there and then it's not available there again. So what do they do?
Yeah, I mean, you really want to try to get that booster in. So you want to get that booster shot in at appropriate timing. For example, the Pfizer's 3 weeks. So you really want to work on that. Generally, it's best to go back to that place where you got it because they have these cards. You get a CDC card, and it lists, you got your first one, and you should be able to go back to the same place and get the second one. We're
Right.
seeing people like in my state, Missouri, some people are driving 3 hours away to go get a vaccine, and then you got to make sure you go back to that place to get revaccinated. Now, if something gets disrupted, let's say you have an MS relapse or something happens, then you really want to get that booster in as soon as you can afterwards, because we haven't studied it. Let's say like you get a booster 3 months later, does it work? We don't know that. Just at this point, we just don't have the data. So I wouldn't avoid the booster, if you miss that period of time, but I would still get the booster. A lot of our boosters and vaccines seem to work out up to about 2 months, and many of our many vaccines in general, sometimes people get the second booster 2 months later. So I'm like, as long as you get it within that 2 months, I think it's important, but I would try to do it as prescribed.
Okay, thank you. What happens if a person learns after the first vaccine that they were exposed to COVID-19 the week prior, but didn't know it when they filled out that form that said, I have not been exposed?
Yeah, well, there's not much you can do at this point. So I've seen that in my practice. In fact, someone that got COVID and they just started vaccinating. They just had the opportunity to get vaccinated a few days before. So it can happen, but there's not much you can do about it at this point. But you would just continue with your vaccination schedule.
Okay, thank you. Now, another one. What happens if a person gets the first vaccine and then develops COVID after that first and before the second?
Yeah, well, you're probably end up delaying that vaccine. That would be a kind of a exceptional case. And so you're probably going to start to mount substantial antibodies. So I think it really depends on how sick you are, what disease-modifying therapy you're on. So that would get I think that gets very complex. So I would sit down and really talk to your healthcare providers to make a decision on what you're going to do there. And everything I'm saying, all decisions in terms of your treatment should really be done one-on-one with your healthcare providers.
Okay, thank you. Now, what happens if a person, can a person with multiple sclerosis take two different vaccines? As it's being said in many places, even outside the US, about giving Moderna and giving Pfizer or vice versa.
I would try to avoid that. The studies, they're both mRNA, they both make the spike protein. But I would probably try to stick with the same vaccine if at all possible. If it's not possible, then that's another story. If where you're going changes what they're doing. But again, that's where it's important to go back to where you originally got your vaccine. Some hospitals, the Pfizer vaccine is stored at a very cold temperature, minus 70 and Celsius, and so it's got to be a very cold temperature. So it's important that because it's so cold, some major hospitals can handle that. More rural areas, they're going to more likely have Moderna, and because of the temperature storage. So it's probably best to just go back to where you got it originally, and they should have quantity to be able to vaccinate you when you go back.
Correct. Okay, thank you for that. Now, if a person, though, all right, speaking about the refrigeration time here, what happens if these shots that are left out in these tent areas where people go into? I know South Florida, I mean, I've heard about it. I've heard from people say that, they pull up to the tent and the person's right there with the syringe in their hand, they're ready to go. And, it was very quick. But how long was that syringe out, and how long is it allowed to be left out before it dies?
Yeah, that's a good question. I don't know the specific protocol about how long each one of these vaccines can be at room temperature, but usually they're stored overnight in these refrigerated, very cold temperatures, and so because usually they spoil within, I think, 24 hours. So because you can in fact see it on the news where they're trying to get rid of all these vaccines because of refrigerator blue. I'm not sure exactly how many hours it can be out of the refrigerator. I haven't been on
Okay.
that side of the administration.
Okay, well, we'll have to find out about that because there are too many
Yeah,
people
I
asking
don't
about
know
this.
offhand.
All right, so feeding back to one of the previous few questions, going with about missing a second dose. But what happens if a person misses their second vaccine, say a Pfizer vaccine, for the full 42 days that we have heard that they're allowed to possibly miss it? Do they have to start the regimen all over again, or can they get that booster at 50 or 60 days?
Yeah, I would have a feeling that they could get that booster at 60 days and still be vaccinated, I would imagine, because most vaccines do work out at about some of them do work at 2 months. But it's an unknown, and we don't really have data because it wasn't studied that way, and so it's a little bit of an unknown. And unfortunately, we don't have a blood test that we can do after you're vaccinated to see, are you mounting great antibody responses? There's nothing commercially available. So again, that's one that you would definitely talk to your doctor. And like everybody else, I mean, I got my 2 vaccines. I've been vaccinated for well over a month. Second one, but I still wear a mask every day. I'm still wearing goggles when I go into rooms with patients and in the hospital. So I think it's important that we just protect ourselves. So even, especially if you weren't able to stick with the full plan, a vaccination plan. But even in the best case scenario, you're only 95% protected, which is great, but there's a 5% risk. So you do want to take all those precautions.
So something you just said, or you were referring to the antibody. So when people have felt that they may have contracted COVID-19, and this is, even going back a few months, and they went in to have the antibody test done to see if they did, or if they had it, how is that test allowed to be given, though, to somebody that had the 2 vaccines to find out if it's actually working for them?
So at this point, we don't know if that antibody works for. I haven't seen any evidence that the antibodies that we look for are to the virus when we do the blood test to see if you've been exposed to COVID-19. Those antibodies are not necessarily produced by the vaccine. So at this point, I don't think we have we don't have a commercial test that we can go in and say, oh, did you mount good antibody response to the vaccine? We do have the antibody test, if you were actually exposed to COVID-19. And so I'm not sure if that vaccine, the antibody response is specific for that spike protein. So when we're vaccinating people, all we're doing is expressing that spike protein. So you make antibodies specifically to the spike protein. But when you actually get the virus, you're going to be making antibodies to various components of the virus.
Okay, thank you for those answers. Next grouping, we have these in groupings, okay? And now we're into the third grouping, or the fourth grouping. We're doing good. All right, so what data or research was utilized to create the recommendation that the vaccine should be taken 12 weeks after an Ocrevus infusion?
So there's, this is based on a committee of scientists and clinicians. And so this was based on a committee. Some of them are, leading immunologists in the world of MS and also MS doctors. And they basically sat down and thought about, for the National MS Society, got a committee together of experts and thought about how these medications work. And so, again, for a drug like Ocrevus, if you knock out B cells, if you wait, a period of time, the B cells, you may have some B cells recover before you get your next dose. So it was about timing of the medications to see if we can maximize the benefit. The problem is as you all know, is that COVID-19 vaccines are not just sitting on the shelf. You just can't schedule things up, exactly when you want to, It depends on where you are in your ranking. Are you a nurse with MS, and then you could go early. If you're a teacher, or you're a grocery store worker, or you're 75 with MS. So everyone's getting called up and found out at different times. And sometimes the timing's convenient and you can kind of figure it out. And other times it's just not convenient. And we just kind of roll with what we're doing. It would be nice to have an individual plan for everybody that worked out. But sometimes it's just better to get vaccinated when it's available to you than trying to delay it, not knowing if you're going to get the vaccine, you get another chance.
So yes or no? Should people that are on a DMT stop?
No, No.
Next.
Now, there may be a question of delaying a month or two, but they should not stop their DMT. And particularly some medications, if you stop your disease-modifying therapy, things can really rebound quickly. For example, the S1P drugs, so there have been cases where the disease really overshot, which includes Gilenya and Maysin, Zeposia. So you don't want to just stop those medications to get vaccinated and the disease can rebound back. They actually did a trial with vaccination with Maysin. And so it was called Siponimod. It was in healthy controls, and they looked at, giving flu shots, and they did it before, on drug, and a temporary interruption of the treatment to look at that. But those people are not at risk for rebound disease. So we don't want the disease rebounding. And so you need a game plan with your doc, sit down, talk about, how this timing should work out. And you got to be patient with your MS centers because they're getting bombarded with questions. So we're trying to work with everybody and try to, orchestrate that. Sometimes it's worth setting up an appointment, even a virtual visit, to figure out that timing. Especially as soon as you hear about a vaccine, it's good to send a message and let us know, and then maybe we can figure that timing out with you.
Okay. Now I really truly need a yes or no answer to this next one. All right.
All right.
Is a diagnosis of MS considered a chronic condition which requires early vaccination? As for the CDC,
my opinion, the CDC says no.
As for the CDC guidelines.
CDC says no.
Okay. Next,
Yeah.
I would like to know about weekend reactivity, specifically with the use of interferon treatments. Plegridy, in my case, is there enough data available to have an understanding of the immunoresponses to the vaccine with and without current MS therapies?
Yeah, so interferon is actually one of the more favorable medications to be on during the pandemic. And so, interestingly, the World Health Organization set up a solidarity trial. And because interferon, beta interferon, has some antiviral properties, they actually studied Revif as a treatment for COVID. And so when we look at our databases, it seems like there's a COVID-MS database. It seems like patients that are on interferon, and the same thing with glutathione acetate, seem to be a less risk for getting COVID based on the numbers. And in terms of vaccination, we don't think that there's any significant reduction in the power of vaccinations on interferon. So there's no reason not to take it. Now, in terms of the trial didn't work out. It was actually just published in New England Journal of Medicine. But interferon did not prevent serious COVID. They were looking at pneumonia, hospitalization, survival. And so it really didn't change anything, but it does not seem to be harmful for the virus.
Okay, thank you for that. All right, so is the, I don't know this question. Let's skip through a few here. So one says that he or she is 60 overweight, have carcinoid tumors that appears to look better due to the MS medicine. Do you think I would still qualify under 1B? Do you think I would?
So it's like carcinoid tumors?
Yeah.
Yeah, I think cancers and certain people on immunosuppressive medications might get in. So you definitely have to look at age, and the states have done different things. Like the CDC put smoking in there. It's not in my state as a pre-existing condition. So you really got to look state by state at what the criteria are. Most of the places where you can register online go through a series of questions, and so that can help you figure out where you are in terms of stratification, get you registered.
Okay, thank you. Next one, person writes, in Tennessee, you can get the COVID-19 if you're 18 years or older and cannot live independently due to a serious chronic medical condition, intellectual or developmental disability. How bad do you have to be able to get it then? And where can I get this information?
So what I would do is specifically, for state guidance, you want to go to your own state public health website, and that would let you know specifically what the criteria are and who who is available now to get vaccinated. So you can register, as I mentioned, with the various healthcare systems. So you can do that through the healthcare system in your areas, but you can also do it through their public health site. And so I think it is important. The county is another place to look. So your county website, but usually the state, each state is going to list which patients are available for vaccination now.
Okay. A person just wrote me from Tennessee stating that in Tennessee, MS is a chronic disease and puts us in the 1A grouping. So that's something new. So for anybody on here from Tennessee, there you go. That's the answer, right? All right. Next one. Are there any specific risks that a patient, an MS patient, could get from having the vaccine that would affect their multiple sclerosis, such as a person saying that their bladder issues are worse since getting the vaccine?
Yeah, so generally we have not seen, and there's been no reports to date of people getting the COVID-19 vaccine that have had any worsening of their multiple sclerosis. Now, occasionally someone will get a fever, which might make their MS worse. So just like if you got a UTI or an upper respiratory infection, sometimes things get a little worse, maybe more fatigued, balance a little worse, bladder urgency a little worse. So, but we don't see any direct disease aggravation of the disease specifically because of the vaccine. So there's no immune attack because you're immunizing someone. There's no immune attack on the nervous system. And as I mentioned with other vaccines, we have not seen association with relapses with vaccination. Now, the one thing I would point out is IV steroids can suppress your immune system. So if you're having a relapse and you're on IV steroids, the recommendation for the National MS Society was wait 3 to 5 days after finishing the steroids before getting vaccinated. So IV steroids high-dose steroids might suppress your immune system, and you may not be able to respond as well to a vaccine during that period of time. You wash it out for a few days, and then you'll probably be good to go.
Great. Thank you for that answer, because that's one that I haven't seen asked yet. What can people with MS when can people with MS under 65 get their vaccine?
Again, it's going to really depend on your state. And it also depends on other health issues and what you do for a living. So I think my first round of people that got vaccinated were healthcare workers. So that included physical therapists, respiratory therapists, nurses, doctors. I have people working in skilled nursing facilities, aides, and nurses and residents. Unfortunately, there's a lot of people with MS that are living in skilled nursing facilities long term. So they were all vaccinated early. So it really, so in terms of just someone healthy that has no other medical problems, 35 with MS, then it really is going to depend on state by state when they get to you, unfortunately. I had one patient who had insulin-dependent diabetes and MS, and couldn't get vaccinated, but smoked, even though smoking makes both conditions worse. Smoked when that smoking was put on there by the CDC as someone that could get vaccinated sooner. So type 2 diabetes was on the list, but type 1 not. So sometimes it doesn't make a whole lot of sense. I think, the bottom line, the CDC is trying to pick who's more likely to end up in ICUs or die from the disease and trying to reduce those numbers.
Okay. Short answers coming up for the following, all right? What happens if I don't want the vaccine?
Well, no one's going to make you take the vaccine. So a lot of people don't. I put a poll out on Twitter at Dr. Barry Singer and put it out there. And we found about 10% of people were no, and a good chunk, maybe a quarter, were watch and wait. And the problem is it's going to be a long haul. If you don't get vaccinated, the rest of the world is going to start to get vaccinated, and then you got 60% or so of people vaccinated and a lot of people exposed. You're going to be living your life if you're on a drug that suppresses your immune system and worry about getting COVID. And we've, had an astronomical amount of people that have died from the disease. And we know there's been fatalities in the MS community. So it's just going to be another long year of, not being able to have a more normal life. And that's tough. I mean, many of my patients with MS have been struggling with this pandemic. They can't get out to they can't go to the gym, they can't exercise, they can't see family members. The anxiety and depression levels are extremely high right now. So I'd love to see people get vaccinated so they can start getting their lives back.
Thank you. Have any of your MS patients had an experience with the coronavirus, and are they still dealing with symptoms or any after effects?
So we have at our center we treat over 4,000 people with MS in the region, in the Midwest region, and we've had over 130 people get COVID. And so, it's a pretty darn scary disease. And we've seen people with advanced disability in skilled nursing facilities that have done well, and we've seen people in the 30s that are fighting for their life. And so it's a pretty horrible disease, and everyone is potentially at risk. So the one thing that I have not seen yet is I'm not seeing a lot of the long haulers. So I'll be interested to see what happens as we start to have more follow-up visits. But I'm not seeing a lot of that long haul that I'm hearing around, and there's long haul clinics being set up. But I'm not seeing that so much in the MS community. So it'll be interesting as things settle down, how many patients are really struggling with that.
Okay, thank you. Next one was, if this vaccine has been developed so fast, which I've heard otherwise to that, but why has a MS vaccine not yet been developed?
Excellent question. So it took about 17 years to develop the mRNA vaccine technology. So this is not, it wasn't, it seems like, okay, the virus just hit us in March and now we got a vaccine already. But this has actually been worked on for quite some time. In terms of vaccinations for MS, that's an interesting topic. It's actually in my podcast on MS Living Well on vaccines. We talk about it with an immunologist. Right now, the only virus that we know that seems to play a role in MS is Epstein-Barr virus, which is mono, so infectious mononucleosis. And so if you get almost everybody with MS has been exposed to Epstein-Barr virus. So one of the questions was, with children of people with MS have small risk, anywhere for a girl, maybe 3 to 5% risk, a daughter or a son, 1 to 3% risk of getting MS. The question is, could you vaccinate them for Epstein-Barr virus when they were little, before they got it? Maybe they wouldn't get MS. So I think there is also one of the companies that was working on the Pfizer vaccine has also been working on seeing if we could vaccinate instead of activating the immune system, suppressing the immune system. So there's some research going on in the world of vaccinations, which would be pretty intriguing. But check out the podcast. I go into that topic.
Great, thank you for that. Will hospitals prioritize MS patients on immunocompromising therapy, since the current Missouri guidelines only prioritize those for immunocompromised due to organ transplant?
Yeah, so right now it's still organ transplant in terms of who can get treated. Now, the one thing that you should keep in mind, especially if you get COVID at this point, is people that are immunosuppressed, there is now monoclonal antibody therapies that are available, which are antibodies that are infused in a vein for people with COVID that are at risk for having serious complications of COVID, but not hospitalized yet. And so we've actually done this, so where patients are given an IV treatment and an antibody treatment to help minimize the disease. So if you do get COVID and you actually get the disease, then it is important to contact your healthcare providers as soon as possible, because you may be a candidate for this antibody therapy. And this antibody therapy is for people that are on immunosuppressive medications, including MS drugs.
Okay, so going a little bit further with this, we're going further with it the whole time, but talking about treatments that could be available, if a person with MS does get COVID-19, what's the best way to approach it? Would remdesivir be like a medication they should be making sure that they get, or what do you think about that?
Well, generally, I think that the approach should be contact two people. Contact your MS providers, so your neurologist, as well as your primary care. And so the paradigms, the treatment has been changing over time in terms of what's appropriate. But I think these antibody therapies would be something that would be high on my list as an MS doc, and to consider, especially if you're starting to get seriously ill from this virus, and you may want to be considered for those antibody therapies. But then I kind of usually turf to the primary doc to kind of consider when to start steroids, when to do. You see some people are being started on antibiotics, and so in terms of what cocktail is appropriate.
Can you tell us, please, which MS medication was being considered?
Considered for?
When that was in research trials for use against COVID.
COVID. So it was Rebif.
Okay. All right. Thank you for that.
So one of the interferons is the one that was studied by the World Health Organization for the treatment of COVID. Fortunately, it didn't change how well people did, but interferon has antiviral properties. So it's for all those people that have been continuing with injections, kind of paid off in the pandemic.
Yeah. So we know that if a person gets sick in general, that they have to watch out if they get a fever. So what can be said about those that might develop a fever after the COVID vaccine?
So the fevers have generally been very mild and transient. So, occasionally more intense, but generally the vaccinations have gone well in our patients. And so, I would just take it with if there's no reason why you can't take Tylenol, then I would take Tylenol and just get your fever down. So I think there's no problem with managing that. Now, COVID, on the other hand, can be really rough. I've had patients with 103-degree temperature for a week. So you can imagine if you've had MS and you've had a fever before, that makes people weak and balance off and extremely fatigued. So you have a fever of 103 for a week, it can be brutal. So, and sometimes you need more caregivers, but the problem is then you got COVID, and unless everybody else in the home has got COVID, you're kind of on your own. So
right.
It's really tough. And I've seen people even hospitalized because they just needed the care that they couldn't get at home. So, fever is a big issue with MS, but the vaccine, it hasn't been a big issue so far.
All right. So now that you answered that way, now I'm going to back up to another one. Is it advisable to take an NSAID or an acetaminophen or something prior to the vaccine? Yay or nay?
At this point, no, we're not advising anybody to pre-medicate.
Okay. All right. Next one is a little bit interesting. What is the efficacy of a Pfizer Moderna vaccines for those over 65 or greater? Getting up into the 70s or 80s. Our MS immune systems are modified in some way. Will this mean that we might get less efficacy than others of the same age, as our older people get less antibodies than younger people anyway?
Yeah, so that's a good question. So as people age, the immune system does not become quite as robust. So where there's changes in the immune system, that makes you more susceptible. As we know, as people age, the rate of infections go up, the rates of cancers go up, and the immune system keeps cancers in check. And so there is some concern that as you age, you may not respond as well to vaccines. I have not seen the breakdown specifically, though, for the COVID vaccines in terms of age groups. I know they did study in older patients as well, but I haven't seen a breakdown where the response rates had diminished in the older patients.
Thank you. All right. So some people complain that they've gotten sore arms after the shot and others not. Why is that?
Well, that's pretty common. Personally, I had a little tenderness when you pressed on your arm, similar to flu vaccine. But you're injecting the mRNA right into the muscle. And so your muscle cells are picking that up and creating an immune response. So a little inflammation in the shoulder is normal over the outside of your shoulder, but that's normal. I had one patient that said they felt like someone hit them like a baseball bat over their arm. So occasionally it's a little more extreme, but most people it's pretty mild.
I had a shot and I couldn't move my arm the next day. It was just crazy. I had to use my right arm to lift my left arm. It was so bad.
COVID or flu?
What's that?
COVID or flu shot?
From the COVID shot.
COVID shot. All right.
Yeah. So, all right, going further, what do we have here? We have what kind of side effects are there for people with MS versus non-MS people with the vaccine? If I get the vaccine, can I take an Avonex shot the same day or the day after, or should I wait a week?
That's a good question. So, especially with our interferons, they can have some side effects. So, some people on interferons, such as Avonex, might get some flu-like symptoms, achiness, low-grade fever, just from their shot. So, some people have some symptoms the day after the shot or overnight. So, you may want to shake that up a little bit. So, but a lot of people take Avonex or beta-seron or Rebif or Plegridy and have no side effects. So if you're one of those people that have no side effects from the thing, I don't think you have to get off schedule. But if you are someone that normally has some side effects from their interferon injections, then you may want to skip a night or shift your schedule off a little bit.
Right. Thank you. All right.
No double whammy.
Another person writes that I'm on Mavenclad. I've had first month in December 2020, second month in January 2021. Aside from looking at my blood work to figure out my levels, more or less, what month should I be thinking about getting a COVID-19 shot?
So that's an excellent question. So we do know with Mavenclad, as I mentioned, about 2 to 3 months is when your counts get to the lowest point, specifically type of white blood cell called lymphocytes. The good news is that most people, the lymphocyte dip is pretty mild. So it doesn't get down into those serious low levels that we would be more concerned about serious infections. But ideally, you want to kind of time it out so that your lymphocyte counts are not at your lowest point. Now, that could be measured by simple blood tests. So your neurologist could look at your lymphocyte count, and then when it's available to you. So ideally, as your lymphocytes recover, may be a good time to do it. So it just kind of depends on when it's available to you and sitting down with but it does tend to peak after your first dose, about 2 to 3 months after the first course, about 2 to 3 months after you take it. So timing can be useful so to maximize your ability to respond.
Okay, so now we're going to get to the last question of those that came in first, and then there are some great questions waiting online as well. But this last question, it has to do with something that you mentioned earlier concerning the long haulers. So MS and COVID-19 long haulers have similar symptoms such as brain fog and fatigue. If an MS patient gets a new symptom at 4 months post-COVID-19, how do you differentiate between the two, and do you treat the symptom the same way or differently?
Yeah, it's an excellent question. And that's what I was just thinking about. Maybe I haven't seen the long haulers because it kind of just goes into MS. So what are the symptoms? Fatigue and cognitive problems. Well, 90% of people with MS have fatigue, and 50% of people with MS have memory problems or multitasking problems, word finding difficulties. So it may be challenging to discern, what's from COVID and what's from MS. Clearly, if there's a change after you've had COVID-19, then we would know. So if there's, you can definitely say, okay, I got COVID and I haven't been the same since, then we'll know. But we may not know. And I think that it's just a really budding science at this point in terms of what's the best way to manage COVID-19 symptoms. So I think we're going to have to learn, and it'd be interesting. In fact, that may be a good thing I could put on Twitter tonight is anybody with MS with long hauler symptoms, because I haven't heard much from my patients so far.
Well, if you put it on Twitter, you have to give me a question so I could put it on Facebook, since you're not on there. And we'll put it on our many pages on Facebook, and we'll see what kind of answers we get.
All right. Sounds good.
That would be great. All right, so now let's go to the online questions. There are a few. A lot of them were repetitious of ones that we've already asked, and then there were comments, and I don't have to get into them as well. So a person writes, what do you recommend about, why is it recommended to get a COVID vaccine before a mammogram? I don't know if you could answer that, but I'm asking you anyway.
I haven't heard that.
Okay, I guess you're not the one to ask about.
I don't know why why it would matter, but that's news to me.
All right. So let's see what else we got here. What about oral steroids?
Yeah,
Yeah.
go ahead. Is there more to
No, so, well, that was the question. What about the oral steroids? So, I mean,
Yeah, so oral, like IV steroids, can suppress your immune system. So if you're on oral steroids, then your ability to respond to vaccine may be limited. So you may want to finish whatever course of steroids you're on before you get vaccinated. Now, if
Okay.
you're on chronic oral steroids, we don't use that in MS, but if you're on chronic oral steroids for another reason, that's another deal. Then you may need to be vaccinated on the steroids.
Okay, thank you. All right, next, I don't know what some of these people write. I'm not knocking it, but some of them write answers to things that were asked, but unfortunately, or even that you answered, but unfortunately, I'm just looking at it now, and I have no idea what they're responding to. So, all right. So if I don't say what it is that you mentioned, I'm sorry, but I don't know what it reflects upon. Okay. All right, so before I get into the next question, Judy writes, Stuart, thanks so much for this program. Dr. Singer is great, and you have been doing a great job with the questions. Okay, thank you, Judy. I've been doing this a long time.
Thanks, Judy. Appreciate it.
I greatly appreciate it. Yes, fortunately, we've been doing so many virtual events every month. It's like, putting on my shoes right now, although I do have problems with them. All right, we have what do you recommend doing if you get a temperature after the second shot?
Yeah, so I would manage it like any other fever. Usually acetaminophen is a good option, which is Tylenol. So that's a good option as long as you don't have any liver problems or anything. That's probably a good option to just kind of keep your temperature down. But you wouldn't expect to have it more than just that first night after the vaccine. If you're having an ongoing fever, then definitely contact your healthcare provider and make sure that you don't have some other underlying infection. A lot of people with domestic bladder infections, just make sure it's definitely from the vaccine. So touch base with your doc.
Okay, thank you. All right, so there are still people out there that are holding off on their Ocrevus infusions because they think that they may not be able to get that until they get vaccinated. Can you tell us a little bit about this, please?
Yeah, so, Ocrevus, again, knocks out B cells. So you don't have any B cells on the treatment. And if you wait about 6 months or so, your B cells are starting to come back a little bit. Now, everyone's different. I see some people where their B cells are not back at a year. So after their last infusion. But most people at 6 months don't have any B cells or very little B cells. So the idea is if you can vaccinate in that little window at 6 months or 7 months, you might be able to get that, create some immune response, B cell response to the vaccine. Again, you still have T cells and you still can mount a response with your T cells. Now, if you wait too long though, so you start waiting out 8 to 10 months, I start to see people's B cells starting to come back into the normal range. So everyone's different on how fast their B cells come back. So sometimes you wait out to 10 months or so, your B cells may be back and you may be at risk for new brain lesions, worsening disability, new relapses. So you don't want to wait too long because the disease can come back. So you want to really focus on the timing if it works out. But some people, it just doesn't work out. They're right in the middle of it. They're 3 months out. They're available for the vaccine. So we've just gone ahead and vaccinated them. And with the understanding that, you're probably going to be protected, but there's a chance that you will not be protected.
Okay, thank you. All right. Regarding the adenovirus vaccines, impact of AD5 versus AD26, likelihood that there has already been exposure and how this might impact effectiveness of vaccines. Can you please also discuss the role of helper T cells versus B cells and whether there will be an attenuated response?
Yeah, so again, the adenoviruses are these viruses that are like a cold virus. The one that's available in AstraZeneca I mentioned was a chimp adenovirus, and so these are viruses that have been genetically engineered. So they take away the part of the virus that can divide and amplify, and just stick in the vaccine component of the DNA that makes the spikes. So when we think about the coronavirus, it's called corona. Corona meaning crown because the virus has spikes COVID virus has spikes all over the surface of it. And so these are the spike protein. So these adenoviruses, what they do is when you give them to the body, and the same thing with the mRNA to make the spikes, is that your immune cells see that and react. And the cells that have memory are lymphocytes, and there's two types of lymphocytes, B cells and T cells. And so B cells make antibodies that can attack and clean out an infection agents such as a virus. But in MS, the B cells form antibodies that attack the myelin. And MS T cells also can attack the brain and cause damage to the myelin. And T cells also are used for memory to fight viruses. Specifically, there's a type of T cell that is used to fight viruses called the CD8 cell. And so CD8 cells help clear viruses out of our body when we're infected. And so there's these two aspects, the T cells and B cells. CD4, or helper cell that the person mentioned, is another type of T cell that helps stimulate immune responses. But particularly with viruses, we're more focused on the type of T cell called a CD8 cell.
Okay, thank you. All right, going back to the Avonex that you spoke about before, a person is asking if it's advisable to take the Avonex shot within a few days after the COVID shot. Can you answer that again, please?
That would be fine, because it's a weekly injection. So you want to wait, instead of taking it at the exact same time, it would be better to space it out a few days if you can.
Okay. All right, next
unless you have no symptoms from your Avonex. If you take Avonex regularly and you don't have any symptoms from it, no flu-like symptoms, then would be fine.
Okay, thank you. Next, person's writing, not knowing when we will get called to get the COVID vaccine, what do you recommend doing if we've already received our dose of Ocrevus, let's say the week before we get called to the vaccine?
Then I would just proceed with it. I mean, unless you want to wait another 6 months. I mean, I would just at that point proceed with vaccination. Again, you want to discuss all these timings with healthcare providers. I'm just throwing this out as I don't want to be giving medical advice. I'm just giving you information. But for my patients, I would be, if the timing came up and they already got their infusion, then it just didn't, it didn't work out, then I would just go ahead and get vaccinated.
Okay, thank you.
You basically are not going to have any. For the most part, people are not going to have B cells 1 month before their last Ocrevus, and most of the B cells are not going to be there 1 month after their Ocrevus. Now, people that are starting these medications, so let's say you're on an interferon and now you're starting Ocrevus, which is going to knock out your B cell, or you're going to start Gilenya or Mazin. So these medications, you may, before you start, or Mavenclad, for example, you want to be vaccinated beforehand if you can. So then the idea is to get your vaccinations in before you start so that you can mount a good response. And then once you get on these drugs that suppress your immune system, then you'll be good to go. So if you can, before you start, especially our patients that are newly diagnosed and are starting medication, we really try to see if we can get them expedited and vaccinated beforehand. Some states you can get a letter that can allow you to get that if there's a medical necessity.
Okay, thank you. All right, next, I'm probably going to mess up this word, but I'll try it anyway. Should the instances of thrombocytopenia, I can't say it.
Thrombocytopenia?
Okay, we'll go with that. It looks just like that, all right? Thank you for saying that.
Low platelets. It means low platelets.
Should the instances of this word, which is immune mediated, concern us that already have, or should concern us that already have a multiple sclerosis? Cut it short.
Okay, so if you have this condition, does it have to do with vaccines or just MS?
Oh, you know something? You're right. Let's skip it. It has nothing to do with vaccine. I don't think. It doesn't say anything about vaccines. So
thrombocytopenia is really, we only have one drug that is associated with thrombocytopenia, and that's Lemtrada. So we do monthly blood tests just to make sure. There's a 2% risk after exposure that you can have low platelets. Platelets are important in clotting, but otherwise we haven't seen an association with MS with thrombocytopenia. I don't know specifically it's been reported with COVID.
Okay, a person named Jennifer wrote something about what I had asked earlier concerning the temperatures of the vaccines, and so I want to read off her response. Vials after dilution. After dilution, store vials between 2 degrees centigrade to 25 degrees centigrade, which is 35 degrees Fahrenheit to 77 degrees Fahrenheit, and used within 6 hours from the time of dilution. During storage, minimize exposure to room light and avoid exposure to direct sunlight and ultraviolet light. Jennifer, you must know a lot about this stuff. Any vaccine remaining in vials must be discarded after 6 hours. Do not refreeze. Okay, thank you for providing that.
There you go.
All right.
Great. 6 hours is the window.
All right, now Karen.
And I think I said minus 70 degrees Celsius, minus 7 degrees Fahrenheit, she pointed out.
Okay, so you take Celsius and you double it and you add 32 and you're pretty close to
really cold.
Really close.
Super cold.
All right. Next one. A person named Karen wrote this at the very beginning, and I want to make sure that I get this in here. It's very long, but I'm going to read it anyway. After COVID vax, I got swelling sensation in the brain, back of my head, between the ears, and swollen lymph nodes above collarbone. Left side of face is stiff from eye to the chin. Not Bell's palsy per the neurologist, since eyes open and close okay. Lifting eyebrows and smiling don't show drooping. Do others have this effect? Have nonstop for 4 weeks now. More with second vaccine. Had to treat and reduce the swelling sensation. Is there a test for this?
So that's an interesting reaction. I haven't heard of that. It sounds like if the lymph nodes are enlarging, that there was some kind of a reaction there with the facial swelling, but I'm not sure what kind of reaction that is. Definitely vaccines can activate the immune system. Immune cells do go into lymph nodes, so that could explain some of that, but not aware of that type of reaction. But obviously they thought it was safe enough to go ahead with the second dose.
Okay, thank you. Thank you for that. Thank you for all your answers. I think that's it. I mean, we're at the bottom now, and there's just some other people that are asking things that are pretty similar to what we've already asked, so I'm not going to ask them again. It has been late. It has been a great time. I do want to say that I'm very thankful that you were able to come on here tonight, Dr. Singer. And again, for anybody that has questions for Dr. Singer that we did not get to tonight, well, he's got his Twitter handle out there already. So I don't know if it's called a handle or what, but it's good enough for me for the moment. So, if you can, write with Dr. Singer directly, then that would be great. But we are already 15 minutes beyond where we wanted to be with this program. So I don't want to stretch it out any further. I do want to thank everybody that was on here tonight. Thank you for being part of this. Hope you join our other MS Views and News programs. You can go to our website and see everything that there is available for each month. Okay, plus you're getting e-blasts constantly about the different programs. We are doing now 8 programs per month virtually. Hopefully in May or June, we are going to start doing some hybrid programs again. Hybrid, new word, okay? But it's going to be live programs, live in-person programs, okay, as well as it being done virtually. So, people can get out of the house again soon. We'll be doing this very socially distanced. We've done this 5 times now since the start of the pandemic. It's been awesome. Nobody's gotten sick from it. And the beat goes on, all right? We do what we have to do, as do the doctors do what they have to do to make sure that everybody's staying as safe and as well educated as they can. So I want to thank, again, Dr. Singer for being with us tonight. I'm looking at the monitor because he's there and you guys are there, all right? And again, thank you for being here, and we're going to say good night, okay? Good night.
Good night, everybody.
Thank you.